Hi everyone, my name is Jennifer Varian and welcome to my video. Today I will be talking about my research dissertation, and this is an investigation of students' attitudes, experiences and perceived barriers to accessing mental health services. I would first like to tell you a bit about myself and why I chose this study. I am a student on the Counselling Master's course in Bangor University. I also did my psychology undergraduate degree in Bangor. It was during my time at university where I first noticed an alarming trend. I had seen from my friends and fellow students that were struggling with their mental health that they would not or could not access mental health services. As I continued on trying to improve my skills as a counsellor, I wanted to take the opportunity to explore further the relationship between students and mental health services and what barriers may prevent students from accessing these services. And so comes the present study. To set the scene for this study, I must first go over some background information. The mental health of university students has received a lot of attention throughout the years. University can be an extremely vulnerable time for students, and unfortunately, research has reported a rise in both the frequency and severity of mental health issues among students. One study by McIntyre reported that 20% of students had experience with suicidal thoughts and 21% reported anxiety on a clinical level. The impact that COVID-19 has had on students' mental health cannot be ignored. Due to COVID-19 restrictions, nationwide lockdowns were introduced that confined people to their homes with only essential activities permitted. This resulted in a shift towards remote learning for university students. Current research suggests that students and those with pre-existing mental health issues are more susceptible to the negative impact that COVID-19 may have on mental health. Lockdowns have been reported to increase students' perceived stress, increase depressive symptoms, and reduce coping mechanisms. Due to the ongoing nature of the pandemic, it is impossible to understand in its entirety the damaging effects COVID-19 has had on mental health. However, it is fair to say that it has only added to the growing list of difficulties faced by students. So, this leads to the question, what can we do to help? The most common type of support recommended to students is counselling. Most importantly, counselling services may prevent students' mental health issues from escalating to what could be a potentially life-threatening deterioration. However, research has highlighted the alarming trend of students not accessing mental health services. One study by Cook found that only 1/3 of high-risk students had accessed counselling services in the past. This leads to the question, why not? Why not access these services that could potentially help? To find out what prevents students from accessing mental health services, I started exploring past research. Attitudes have been reported to be the most significant predictor of accessing services. The first attitude barrier that I found was stigma. Feelings of embarrassment and shame associated with self-stigma can make it really difficult to access the appropriate services. Another attitude was the attitude of ineffectiveness. The lack of belief in the appropriate services could prevent people from accessing them. And another attitude was the attitude towards GPs. Many young people viewed GPs as unqualified to help with mental health issues. As GPs play a crucial role in providing access, this is really worrying. Accessibility issues can also act as a barrier to accessing mental health services. The role of GP was again identified, possibly giving medication instead of a referral to mental health services. Long waiting lists and cost of service, these are really significant barriers according to the student population. However, it is worth noting that there is an uncertainty regarding accessibility issues. These are greatly dependent on one's geographical location. What may be considered as the most pervasive barrier in one area may not be that significant in another area. Other factors that can predict or prevent future access are previous experience with mental health services and previous or current experience with mental health issues. Research is really varied when it comes to these two factors. Some studies found that past experience with services meant more positive attitudes and more likely to access these services in the future. However, other studies found the opposite, that past experience was linked to more negative attitudes, which decreased the likelihood of future access. Same goes with previous or current experience with mental health issues. One study found that experiencing psychological distress meant that someone was more likely to access services. However, other studies found that no, it's the opposite. Experiencing psychological distress, experiencing symptoms actually decreased the likelihood of accessing services. Research is evidently very varied when it comes to how these two factors can act as barriers or facilitators to accessing mental health services. And so brings me to the present study. Number 1. I hypothesize that counselling experience will have an effect on attitudes towards accessing mental health services. Number 2, I hypothesize that experience with a diagnosis or symptoms will also have an effect on attitudes. Number 3, I want to explore the perceived barriers to accessing mental health services according to students. And lastly, due to the rapid changes mental health services have faced because of COVID-19, mainly the expansion and reliance of remote services, I wanted to explore the attitudes and preferences of face-to-face services versus remote services. Now I'm going to talk about how I performed the study. This study incorporated quantitative and qualitative analysis. 168 participants took part, and these participants were recruited from Bank University or social media advertisement. These participants took part in an online questionnaire. 11 participants were randomly chosen to take part in semi-structured interviews. The independent variables of this study is first, experience with services, and this split participants into 3 groups. First group is previous experience with counselling, second group is currently experiencing counselling, and the third group is no experience with counselling. Looking at the second independent variable, mental health diagnosis, and this split participants into 4 groups: no diagnosis, no symptoms, diagnosis and symptoms, no diagnosis but experiencing symptoms, and having a diagnosis but not experiencing symptoms. Here are the dependent variables of the study. The first one is attitudes. I used the inventory of attitudes towards seeking mental health services questionnaire. This had 3 subscales: psychological openness, help-seeking propensity, and indifference to stigma. The second dependent variable was uptake of counselling services. I wanted to explore what kind of services participants had accessed in the past and what numbers go into face-to-face or remote services. Perceived barriers. Participants were shown a list of possible barriers gotten from previous research and were asked to pick which ones they thought were the barriers to accessing mental health services. With preferences for different modes of counselling, participants were presented with a list of different forms of counselling: face-to-face, telephone, video call, text, or online counselling, and were asked to pick which ones they had a preference for. This study followed the BPS and the BACP guidelines for safe and ethical research practice. It was also approved by Bangor University. Signposting was performed as many of these questions touched on past experiences with mental health issues. Signposting was performed to the Bangor University Counselling Services, GPs, and organisations such as Samaritans. The role of the researcher was very important within the qualitative interviews. The researcher was constantly aware of the emotional state of the participant and had let the participant know that they could withdraw at any time without penalisation, and if at any point they felt upset or they did not want to answer a question, that was within their right. Okay, so I finally get to show you some of the results I've gathered from the study, and the first thing I want to look at is attitudes. I've included the overall score and the 3 subscale scores, and these are the average scores among all the 168 participants. The first thing I want to point out is the overall score. This was out of a possible score of 96, and the 3 subscales are out of a possible score of 32. So you can start to see that these are quite low scores, and this is something I'm going to talk a lot about in the discussion. Now, if you can remember back to my first hypothesis, I expected that experience with services would have an effect on attitudes towards these services. However, as you can see, this finding is insignificant. Now, what this really means is that there was no significant difference in attitude scores between the 3 groups: previous experience of counselling, currently experiencing counselling, and no experience of counselling. And the same result was found for mental health diagnosis. Once again, insignificant, and this means that there was no significant difference in attitude scores between participants who identified as having a diagnosis, not having a diagnosis, experiencing symptoms, or not experiencing symptoms. Here we can see the preferences for different types of counselling. As you can see, face-to-face is the most preferred form of counselling. 70% of the participants in this study had a preference for face-to-face. You can compare that to 76 participants for online, 72 for video call, 64 for text, and 61 for telephone. Yes, face-to-face is the most preferred. However, there was a significant preference for some of these remote services. This graph represents the perceived barriers to accessing mental health services. As we can see, long waiting lists was the highest rated barrier within this population, followed by cost of service, feelings of embarrassment, and feelings of shame. So, the accessibility issue of long waiting lists was rated the most important barrier to accessing services. Cost of service, this coincides with the financial burden that students face. Feelings of embarrassment and shame, this coincides with self-stigma, showing that it still is a significant barrier. Thematic analysis was performed to identify the main themes and sub-themes for my qualitative interviews. Accessibility issues was one of these main themes. Here below you can see a range of sub-themes. Misdirection to services. This explained confusion over accessing the mental health services within the university or their GP. Lack of direct access, and this pertains to how accessing mental health can be a multiple step process, and if you are struggling with your mental health, you may not have the motivation to carry on with these steps. And really this ties into the role of GP. If your GP does not give you a referral or does not support you to go on to further access to mental health support services, this can be very challenging. Long waiting lists again were highlighted, and especially the dangerous impact this can have if you are struggling with your mental health. And lastly, the accessibility of remote services. Something not to take for granted within the student population is everyone having a working phone, laptop, or reliable internet connection. Not possessing these can act as a real barrier to accessing remote services. So what does all this mean? Well, first of all, if we look at the attitude scores, these were extremely low, even when compared to past studies that investigated UK university students. This is worrying because, first of all, we know that students may be struggling with their mental health now more than ever, and we also know that attitudes are one of the primary predictors of future access. Therefore, we may suggest that this population is more at risk because we know they may be struggling with their mental health. However, by their attitude scores, they are less likely to access services. Moreover, if we look at the counselling experience and mental health diagnosis, these had no effect on attitude scores. Again, this is worrying. We would hope that people with past experience of counselling would have more positive attitudes. Similarly, we would hope that those who are struggling with their mental health or experiencing symptoms, that they would have more positive attitudes to the services that could potentially help them, therefore be more likely to access them. However, this was not the case. This contradicts past findings. Yes, there was variation that counselling experience could have a positive or a negative effect, and same with mental health diagnosis. However, the fact that they are insignificant may suggest that there is a lot of work to be done. Looking at our face-to-face versus remote services results, we have to start at preference. Face-to-face was the most preferred form of counselling, and this coincides with past research. However, the results of this study suggest that there is a growing preference for remote services. This is a positive finding. This may suggest that there is a growing acceptance towards remote services, and this possibly could be down to the remote shift that has happened since COVID-19. However, accessibility issues still apply, especially with digital exclusion. We cannot take for granted that everyone has the resources, such as a working internet connection, a laptop, to access these services, even among the student population. If we look at our perceived barrier findings, we can see that self-stigma, like feelings of embarrassment and shame, are still significant barriers experienced by students. This supports past research that has suggested that self-stigma may not be the most pervasive barrier, but it is still a significant barrier that can prevent students from accessing services. Next, if we look at the misdirection, this finding was not reflected in past research. Now, this may suggest that it's a very niche and very particular problem experienced by students. Future research is required to further investigate this problem, but to also investigate possible interventions. Next, if we look at the lack of direct access to mental health services, This summarises the long process that it can be to access support and the potential detrimental effects this can have on students. This is definitely supported in past research. There has been a growing demand for direct and easy access to mental health services. Lastly, long waiting lists. This was rated as the most significant barrier within the study, and this definitely supports past research. Long waiting lists can have a really detrimental impact on students, especially those who are struggling with their mental health and in desperate need of support. Some possible limitations to the study is how the experience with mental health services was defined. There is no formal definition for this within past research, and in the present study, past experience was defined purely by counselling experience alone. However, previous studies incorporated psychologists, psychiatrists, mental health nurses into their definition. This variation may explain why we had an insignificant finding compared to that of other studies. Similarly, there was another issue with the definition of mental health experience. Within the present study, we used a broad definition of diagnosis and/or experiencing symptoms. However, past research has focused on specific disorders such as anxiety or depression, with varying results. This broad definition may explain some of these contradictory findings. Considering the extremely low attitude scores that were present in this study and the significant impact attitudes can have in accessing services, I believe that future research should focus on ways to improve attitudes. This can be done through mental health campaigns that may describe the process of accessing mental health, where to access mental health services, and the benefits of accessing mental health services. Hopefully, this can be done to improve attitudes and further improve access to mental health services. The take-home message from this presentation is, first of all, we need to make sure that as counsellors, our clients and these students can return to services if they need to. Considering that we found past experience with counselling had no effect on attitude scores, this is something we need to work with. Possibly having that conversation with our clients and explaining that there is always an open door to return to services. Considering that the journey of mental health and well-being is continuous, this would make sense that the access to mental health services is also continuous. Lastly, we might have to reevaluate what we know after COVID-19. Considering these extremely low attitude scores, this may be a sign that COVID-19 has had a massive impact on how students view mental health issues, but also view mental health services, and this is something we will have to look at in the future and make amends for. I hope you enjoyed today's talk and thank you so much for watching. If you have any questions, please leave a comment below or you can email me. I will leave my reference list that I used to guide this dissertation and presentation on the next slide, so please have a look if you would like. Once again, thank you and all the best.